Good morning, folks. John Adamson, the Rehab and Documentation Guru, heading to my first patient after a meeting. And that's why I wanted to do this video, because during the meeting we got into a big discussion. It was a good discussion about maintenance therapy. Not only maintenance therapy, but maintenance nursing. There's two patients that were brought up concerning this. The first one, I would say, probably did not need maintenance therapy. A patient with a progressive neurological dysfunction who at this point was being maintained for ADLs and functional mobility with very simple range of motion exercises. And the family wanted the therapist to come in. Even though they were doing a good job of taking care of the patient's personal needs, they were not willing to follow up on exercises for basic range of motion to prevent contractures. Now, Medicare does not pay for maintenance therapy just because you have an unwilling caregiver. Sorry about the GPS. They don't cover that. So you have to always assume that there is a caregiver. And I've talked about this in another video. If you think you might have a patient that should be on maintenance therapy, you need to pretend there's an imaginary caregiver there. This imaginary caregiver is fully willing, fully capable, and fully available to do whatever you train them to do. Every patient gets an imaginary caregiver, regardless of the setting that they're in. If you can train that imaginary caregiver who is fully willing, able, and available to do what you're training them to do, if you can legitimately train them to do it, and it would be safe and effective to turn the patient over to them to maintain the patient. Sorry guys for the GPS. If you can do that, it's not a maintenance therapy case. So the first case we talked about was a neurological patient that clearly should not be on maintenance therapy. The second patient was interesting. It was more of a nursing need, chronic COPD CHF patient. Very complex, very disabled because of their disease process. And the nurse was basically pointing out that they were getting ready to wean the patient off caseload, recertification was coming up, and they weren't sure they could justify staying in. And I pointed out to them that, you know, if you are the variable that's keeping the patient out of the hospital because of the complexity of the nursing care, even if the patient's maintaining, or even if they're declining in function related to their disease right now, then you have a skilled maintenance case, whether it's for nursing or rehab. So in the second case, and there's a nurse manager there that totally agreed with me, you keep them on caseload. Even if you're only seeing them once a week and your assessment and training and expertise are keeping the patient safely and effectively in the home, and that imaginary caregiver that is willing, available, and able to be trained couldn't pick up on the fine nuances of medical complexity that are keeping the patient out of the hospital. If they can't do that, you have a skilled maintenance nursing patient. So anyway, maintenance therapy, again, pretend you've got this perfect caregiver on all your patients. If that caregiver can be trained to do what you're doing and safely and effectively maintain the patient, that is not maintenance therapy, maintenance nursing patient material. If that perfectly willing, able, and available caregiver that's imaginary can be trained, you don't have a maintenance case. Anyway, John Adamson, the Rehab and Documentation Guru, giving you a synopsis of maintenance therapy. If you're interested, in the very first week of February, I'm giving a 2-hour webinar online through an organization called Allied Health Education. In that webinar for 2 hours, which is CE approved, I will tell you exactly what you need to do to prove maintenance. And I'll give you background behind the maintenance decision, the Glenda Jimmo decision. Again, that's Allied Health Education. Anyway, take care, God bless, and have a great day.